Good morning, everyone. It's good that you guys are all here. I see that you're all from all over the world and everywhere. So thank you for coming and thank you for seeing and coming to our institution. So I'd like to, and thank Jill also for inviting and collaborating with us to hold this conference. So what I'd like to do first and foremost, without further ado, on your schedules is to introduce my partner here, my neurosurgeon, Dr. Andrew Little, who is going to perform a live surgery for you guys. And I want to emphasize, please, no photographs are permitted for reasons, confidentiality reasons. Dr. Little is a neurosurgeon here, and his primary focus is on pituitary surgery and also research in this field as well. So we both have done a fair amount of seeing patients and collaborating and doing a lot of research. And we're happy to share with you the surgery that he's going to perform in a few minutes or so. So, Dr. Little.
Morning. Just give me a moment to set up the laptop. So the first thing I'd like to do is just ask for a little grace this morning. The good news is the patient showed up. These surgeries, they're not a performance, so it's not something that's been rehearsed. You're going to see kind of what we do every day. And there can be little bumps along the way and technical difficulties. Perfect. All right. So first, I need to congratulate the team here, the multimedia team, the video team, Craig, Jordan. It's a massive amount of effort to coordinate these live surgeries and to work out the technical aspects of it. Second, I want to express my thanks to the patient. We have a patient who's willing to do this as a way to educate and raise awareness to pituitary disorders. He was very much willing to participate in this event. So I'd like to thank him and his wife. Okay, so here we go. So I thought I'd do is take a couple minutes to tell you about the patient and then talk through the surgery and what you'll be seeing. So he's 77 and he's had these incapacitating headaches for a couple months and he's been complaining of blurry vision. He also happens to have adrenal insufficiency, and that's because the tumor is pushing on his pituitary gland and causing it to not work very well. So his adrenal glands aren't receiving a signal from the pituitary gland. He has a non-functioning lesion, so meaning it's not secreting any hormones. Okay, let's see. I'm going to try to point if I can. I can't. Sure, if you dim lights, thank you. Okay, so in the middle of the screen, first let me orient you. On this particular image, you see the patient in profile. So his nose is in this direction towards the left side of the screen, and the back of his head's towards the right side of the screen. In the middle, you'll see an oval-shaped white object. That's the tumor that we're removing today. And just in front of it, you see this dark space, kind of this dark saddle, and that's the air in the sphenoid sinus. So during the surgery, we use the nose as a corridor. Many of you likely already know this. We use the nose as the corridor to reach the tumor, and that's because it allows us in a minimally invasive way to sneak underneath the brain and to remove the tumor. And so the dark black that you see on the MRI scan is just air in the sinuses. So that's, for surgeons, that's the corridor. That's what we use as the potential space to reach the tumor. Up above the tumor will be the optic chiasm. So that's the apparatus that provides vision. This is a view, we call it a coronal view. So imagine the patient's nose is coming straight out of the screen. So the nose is coming straight towards you. And you can see the tumor in the middle, which is that bright white object. And then the brain is that gray substance up above. Now you notice on either side of the tumor are these two dark circles, two black circles. And those two circles are the carotid arteries. Those are the arteries that feed the brain with blood. And so the tumor always sits in between them like a goalpost. The carotid arteries act like basically like a goalpost, a football goalpost, and the tumor's right in the middle. It's always that way. All right, so let me help orient you with the relationship of the pituitary gland to the brain. This is a video prepared by our neuropublications office. And so you can see the gland there in the middle, that P-shaped object, and up above it is the optic chiasm, that X-shaped object. And so here it is in relationship to the rest of the brain. So the key is we need to find a safe way to remove these tumors and a minimally invasive way. In most patients, we discharge after surgery. So for most patients, it's a one-night stay. The challenge surgically, of course, what you'll see is that the pituitary gland is housed within this bony saddle. And so it sits in this saddle. We need to find a way to get to that safely. And so you'll see that today, where we will kind of drill through the thin bone. Usually it's quite thin, usually kind of tissue paper thickness, in order to reach the tumor, which is sitting inside that saddle. So let me just walk you through an animation of what the surgery will look like. Intraoperatively, it won't look like this at all, but the animation makes it look very appealing. All right, I'll just kind of talk you through it. So this will be the orientation. The pituitary gland there is in the middle, that yellow halo around it. And so we'll use that camera that goes in through the nostril, so we don't make any incisions on the face. There's no bruising. We used to do the surgery by making an incision underneath the lip, but we really don't do that anymore. So we use the nostril, and then you can see that area, the sphenoid sinus, just underneath the pituitary gland, and the tumor is that purple object. So here's the camera that we use inside the nostril. That's what gives us the visualization. And for the modern generation of surgeons who grew up playing video games, this is a very comfortable way to do surgery, because you're looking at the monitor the whole time. And so we remove the mucosa, which is the covering over the sinuses, and then we're left with a little bit of bone. And so we drill that bone and open it until we're looking at the underside of that saddle, that bony saddle. And so there's a projection of the gland. So then we proceed to remove the bone, which I'll show you today, and open the dura. The dura is a hard covering around the brain. And there's the tumor, that purple substance. And it always just comes out like that. Yeah. Yeah. So we always show our best case. That's the way the surgeons do it. And then the pituitary gland is that pink substance right behind it. And so then we close it back up and remove our instruments, and then we're done. And so the patient will be in the hospital for one night. This is an example of some of the instruments that we use. They're all very long and thin and quite small. The curettes you'll see that we use to remove the tumor are only 3 millimeters in size at the end. So, and the drill that you see during the surgery is only 3 millimeters in size. And it's made of diamond. It has a diamond tip, and that makes it much safer to remove bone, but to preserve soft tissue. So that's the patient for today. Dr. Santarelli is the otolaryngologist who's helping with me today doing the surgery. So he's already started. And this is the rest of our team. So thank you very much. And I look forward to showing you successful surgery.